As the principal investigator of the study, of course, I hope to have like a study showing some differences in terms of outcome. Although I think even when a study is negative, it's very important to report transparently the results, and that's also very important data. I have, in full honesty, a hard time to predict what's going to happen based on this preliminary analysis that looked only at the impact on management. It's hard to know if this will really translate into difference on PSA progression. So the endpoint, the primary endpoint is the success rate defined as PSA progression following salvage radiation therapy at 5 years. And so we exclude from the primary endpoint analysis patients who do not receive salvage radiation therapy because finally something happened to change the decision of the treating physician and the patient.
I think we can hopefully expect an improvement in EFS, the primary endpoint of the study, based on the results of the Empire 1 trial, which had compared standard of care imaging, which at that time did not include fluciclovine, to fluciclovine-based salvage radiotherapy. Of course, in this case, there was a minority of patients that got the fluciclovine PET in the control arm, which could have, impacted outcomes. But we would expect, based off that prior study, that this one too should be positive. I'm not sure about MFS or OS, primarily because it wasn't powered to detect that. Thankfully, in prostate cancer, we do have good treatments even in the second salvage setting, and certainly for OS, we have good treatments in the metastatic setting. So it'd be very difficult to have a study showing a difference in those outcomes, especially a single institution randomized trial.
In this trial, where you have half the patients having, a more accurate and sensitive imaging modality up front in the beginning, depends on how you're going to analyze the endpoint. The MFS is going to be complex there when half the patients had PSMA PET at baseline.
Here, the trial looked at the impact of doing the procedure, the PSMA PET, versus not. Now, I think we'll demonstrate that it's better to do it. Now, the different patterns of disease you can observe on the scan, we're not sure yet how to best use this information for the best treatment outcomes. So maybe one of the next future trial could be everybody gets a PSMA PET scan, and based on what we see on the PSMA PET scan, we randomize patients to different treatment arms. So that could be one next study.
I think, PSMA PET imaging is here for prostate cancer, and the challenge for clinicians is how best to use that, actually. And so a lot of trials ongoing now, are including that, in how you stage the patients. And I think that we need to develop treatment paradigms based on modern imaging.
I completely agree, and I would just echo that, we now consider something like MFS to be, a hallmark endpoint, a surrogate endpoint for overall survival that can be used in clinical trials. But as was alluded to, MFS has been defined based on conventional imaging. So I think there's a lot of work to be done to see, is MFS defined by PSMA really the same thing? Because as been stated numerous times, now we're using it widely, right? So, patients are being diagnosed as having metastatic relapse based on PSMA PET. That's going to impact many of our decisions in treatment moving forward, and I think we need some more research in that space as well.